Good afternoon, everybody. I was asked to give a talk about the poor prognostic factors for post-prostatectomy incontinence surgery. So, this is my disclosure. I have no disclosure with this subject. So, incontinence in male after prostatectomies has a great impact on quality of life. And we can manage them with the surgeries, but inevitably we have failures after the surgery. So there are some options of for the incontinence with the surgeries. The first one is bulking agent and male slings, such as bone anchoring sling, Transobturator slings, and adjustable urethral slings, and finally artificial sphincter. As you know, the bulking agent were used for the male incontinence, but as you see in the slide data, so there's a very low cure rate. Yesterday in ICS meeting, the bulking agent was not recommended as first-line therapy for PPI. So, but the injection of bulking agent does not appear to afflict the post-operative results of artificial sphincter implantation. And also the post-injection inflammation can cause frozen urethra. So I'd like to introduce some of the male slings. The first one is bone anchoring sling, the advanced. The cure rate is up to 66%, but the erosion rate is very low. Infection rate is very rare. But after irradiation, the patient had a significantly lower cure rate, is about 25%. But this sling implantation is not interfere the implantation of artificial sphincter. So there are several risk factors for failure are reported. So degree of incontinence more than 400 grams on 24-hour PET test, and radiation, poorly compliant tissues, and non-synthetic sling and prior artificial urinary sphincter. The second sling I'd like to introduce is the advanced. Yes, we have first generation and second generation of advanced. That's advanced XP. So there's a 2-year outcome. The cure rate is about more than 70%, but they excluded the irradiated patients. The complication of the Clavin-Dino classification, 5% have 3B. So 21% have urgency, 1.1% SGI, and 21% retention. So there's no explantation. This is one of the data that I looked at, so with long-term follow-up, 3 years follow-up. So they included 68 patients with PPI. So for the risk factors, so they found that 6 out of 7 patients will, with the pre-operative 24-hour PET weight, more than 200 grams, failed and went on salvage procedures. This is the other reports. So a minimum follow-up 6 months. As you see in slide, the success rate is quite high, about 74%. But previous radiation also, has a higher failure rate, the 41% versus 15%. So there are suggested several factors, risk factors of failure of transobturator slings. There are prior stricture, high pad weight, more than 200 grams, radiation, and weak radial sphincter function, failure to turn over the sling, poor suture fixation. And also higher pad use, low maximum closing flush, a low abdominal leak point pressure. There is a controversy about this one, but there is a deterrence overactivity, low functional urethral length suggested as risk factors for sling surgeries. This is different to sling ProACT. This is adjustable urethral sling. The ProACT has about 70% of cure rate with a mean of 2.5 fluid adjustment. But there's about 20% explantation rate. Despite this surgery is low invasiveness, but the complication rate we have to characterize that. But radiation therapy is clearly as a negative factor in the series. Remix is another adjustable sling, 65% cure rate, 6% of explantation rate. Argus is another sling, so it has about 80% cure rate, but 70% explantation rate. But they have about 45% of prior sling or working agent patients. They insist that the patient with radiation therapy demonstrates similar explantation rate. The Atoms is one of the adjustable transobturator sling, but it's quite different from others. They report that there are the poor prognostic factors such as poor Carson comorbidity index, preoperative positive urine culture, severe SGI, and previous implant. They report that radiation therapy is not a risk factor at all because they insert this device out of the radiation field. That is the difference point to artificial urinary sphincter, they insisted. Artificial sphincter, as you know, the highest cure rate, about 90%, but there is a 20% explantation rate. So, you know, the overall complication rate was so high. The reason why there is a lot of long-term data we can find it. So there is some controversy about the risk factors of artificial urinary sphincter. In some series, the compressed urethra from prior sphincter surgery, radiation, or urethroplasty had a significantly higher risk of failure. I'd like to mention briefly about the urodynamics of the post-prostatic incontinence, when and how. So urodynamic is indicated in the evaluation PPI if there is a question whose answer can have an impact on treatment algorithm or outcome. There are important questions such as pathophysiology and bladder contractility and high pressure storage function, overactivity, and so on. However, leak point pressure, as you know, neither correlated with degree of symptom, nor does it typically alter the plan of treatment. This is one of the data of the urodynamic findings in PPI. As you see, the sphincter incompetence is about 60%, but blood dysfunction may coexist this, and this is another coexisting factor. We can find it by urodynamics. So, preoperative finding of diffuse hyperactivity, impaired contraction, low VLPP, pleural obstruction, reduced blood compliance will not associate with the surgical outcome of sphincter. So, sphincter success does not differ in patients with normal versus underactive bladder. But in contrast, adequate detrus contractility is necessary to expel urine and to pass a compressive sling. So given that retention rate is higher in retrourethral sling, about up to 23%, this procedure should be avoided in patients with underactivity. The degree of incontinence is a very important factor. So there are a lot of papers regarding this as risk factors. The severity of incontinence affects outcomes. So in men with slings, to more than 200 gram urine leakage per day, also shows low success rate. For each 1 gram increase on 24-hour PET test, cure rate decreased by 0.4%. In contrast, sphincter demonstrated excellent long-term outcome with 90% satisfaction rate, regardless of degree of incontinence. So we think that the severity incontinence is now related risk factor of the sphincter surgeries. There's one interesting surgery with the quadratic sling, 4 arms of sling, This is and fixation showed no difference. Dr. Committer insists that there's no difference of success rate between mild, moderate, and severe leakage. As you know, diabetes mellitus is increased risk of implant infection of penile processes. As in artificial sphincter, DM patients has a great 5-year instance of erosion infection. So DM was independently associated with increased risk of erosion and infection. Fragile urethra is defined as history of pelvic irradiation, previous failed surgery, previous urethroplasty, or cystoscopic and clinical finding urethral atrophy. So sphincter demonstrates high content and improved rate. Only 7% require extirpation due to erosion. But if there's a concern about severe urethral atrophy identified during the operation, so we can have several options for transcorporeal approach or modified cuff or relocation of cuff should be considered. This is one of the large cysts that I look at with the sphincter, more than 1,000 cases. The 31% had a history of previous ICS surgeries, but they did not find any patient-related risk factors for incontinence surgery failure. The secondary surgery-free rate was 9% at 1 year, 74% 5 years, about 60% 10 years, and even 40% at 15 years. This is my data, my humble data. So this is not a prospective study, but I performed the sphincter and Argus, and we found that in multivariate analysis, the pelvic radiation and mixed incontinence and severe symptom were the independent risk factors for treatment failure for PPI.
Can you please come to the
this is my last slide. So in summary, pre-operative UDS could not predict the treatment outcome of PPI surgery. DM was the independently associated with increased risk of retrourethral infection. Severe incontinence and fragile urethra were the preference factor for Sling surgery. And the fragile urethra were not remarkably associated with an increased risk of treatment failure of artificial urinary sphincter surgery. Thank you very much for your attention.